Now, I tried to think of a witty title for my presentation tonight, but I couldn't, so all you get is PFOA, but I think that summarises quite nicely what we're going to talk about tonight. So just a bit about me. So I've got a very tolerant wife. She sort of tolerates all the things that I do, the various hats that I wear. I've got 2 young kids, 10 and 7, so this is a very small moment of peace with the kids. I think probably 5 seconds later they would have been tearing each other's hair out. But yeah, so one of the big things I've done in the last few years is Christian and I set up this place. So yeah, we're very sort of proud, that you guys, are super keen to come and listen to things like this that we put on. So thank you very much for being here. But yeah, this was a really big undertaking, and it's actually quite nice to have Reese here, who actually fitted out the building for us as well. So thank you, Reese. One of the other big things that I've sort of taken on in the last few years, well, I want to say the last few years. Back in 2017, I started a research degree. This took me a very long time to finish, but I finished it last year, so it was a very, very long undertaking. But my topic was essentially all around patellofemoral osteoarthritis, so you guys are in for a treat tonight. So just a bit of an overview of what we'll try to cover in this session tonight. So we're going to touch a bit on knee osteoarthritis, and this is sort of just to get a little bit of an understanding of where the evidence sits, and sort of contrast that with what we can see with patellofemoral osteoarthritis, because as you'll find out, there's not a great deal out there on PFOA specifically, so we need to draw a little bit of information from some other sister conditions like knee osteoarthritis. So we are going to touch on obviously the importance of patellofemoral osteoarthritis and why it's unique. We're going to, again, delve into some of the management strategies for knee OA, again, just so we can draw some parallels for PFOA as well. We want to go through some of the evidence for patellofemoral osteoarthritis, and there are a few studies out there, so we'll try and distill that a little bit tonight. And then also a little bit about what influences treatment choices, and Christian sort of already alluded to this a little bit tonight, just about language and kinesiophobia and things like that. So we'll try and wrap that up a little bit to do with patellofemoral osteoarthritis towards the end as well. So knee osteoarthritis. So how common is it? It's exceedingly common. So in the most recent global burden of disease study done in 2022, so they estimated there was about 3.2 million Australians that had some form of osteoarthritis. 1.9 million of those were knees, which actually sort of makes knees these days the most common joint affected in Australia. So this is a little bit different to other places around the world. More commonly we see hand arthritis, which is a little bit more common, but knees seem to be the most common joint affected in Australia. And who gets it? So knee osteoarthritis has some similar determinants to other non-communicable diseases. So we're talking things like cardiovascular disease and perhaps diabetes and things like that. So there is actually a lot of overlap between a lot of the risk factors that we see with knee osteoarthritis. And as you'll find out, there's a fair bit of overlap obviously there with patellofemoral as well. And trends over time. So again, in this most recent study done in 2022, they found that there was a 126% increase in knee osteoarthritis since 1990. So this is due to a lot of different reasons. We've obviously got a very ageing population, but there's a lot of other modifiable risk factors that are probably on the rise as well. So things like obesity is quite a large risk factor for osteoarthritis, and we're definitely seeing a big increase in these numbers as well. So yeah, some big increases, and they're obviously estimating that these numbers are only going to increase further over the next few years. So patellofemoral osteoarthritis, so important and unique, and that's not because I spent 7 years doing a research degree about it, but there's a few reasons why this particular compartment is particularly important. So it is actually the most common compartment affected. So the stats are around, so in people that are over the age of 50 that have a symptomatic knee problem, so 64% of these people have patellofemoral osteoarthritis compared with about 44% that have some tibiofemoral involvement. So you'll say, David, that doesn't add up to 100%. But these are obviously not mutually exclusive events. People can have obviously combined presentations as well. So we do see a lot of that happening in all 3 compartments. Because of that, like these people actually having a lot of symptoms with patellofemoral osteoarthritis, or these people with knee pain over the age of 50, we can draw a conclusion that patellofemoral osteoarthritis actually probably contributes more to symptoms than what we see with tibiofemoral osteoarthritis, and therefore can potentially have a greater impact on quality of life, also economic productivity, and those sorts of things as well. So isolated symptomatic patellofemoral osteoarthritis is also a marker of future development of tibiofemoral disease as well. So, and this is important as well. So people obviously, it may start sort of in the patellofemoral joint, but then it tends to progress to other parts of the knee. So that's another sort of important feature. And one of the sort of more unique things here as well is potentially the chronicity. So this is only a proposed risk factor at this stage, but it is due for a bit further research, but there's been a proposed continuum between patellofemoral pain and patellofemoral osteoarthritis as well. So often by the time these people are presenting with patellofemoral osteoarthritis in the clinic to you, it's possible that they may have had pain for 20 years. So that adds that sort of additional layer of complexity to these presentations that you might see in the clinic. So what causes patellofemoral osteoarthritis? And we did allude to some of these things just to do with knee osteoarthritis before. So we understand that they have some similar risk factors. We have some modifiable risk factors. We have some non-modifiable ones as well. So overweight or obesity we consider a modifiable. Female sex, obviously non-modifiable. Age, and then manual workers are also considered a higher risk of developing patellofemoral osteoarthritis as well. Some major joint injuries. Now these are probably not dissimilar to other tibiofemoral disorders as well. But actually, in preparing this talk, I actually gave Christian a call the other day and I said, mate, I need some stats around instability and progression to osteoarthritis. He goes, no, don't have any. So this research really just hasn't been done. So it obviously makes logical sense, right? We have an isolated patellofemoral issue. There might be some sort of isolated sort of articular surface injury. We might expect that that sort of may end up in a patellofemoral problem later on with something like osteoarthritis, but we don't have those stats yet. ACL injury, now this is an interesting one. So we do actually see, and this has been a sort of recognised and identified problem, so people following ACL injury, I think some of the stats are around 50% of people following an ACL injury will probably have some sort of osteoarthritis in their knee within 10 years. Now, within the patellofemoral cohort, it was interesting, I was doing a bit of search again for some data around this. I don't know if any of you have seen, I think the movies might be Something About Mary, where the guy in the car, he was talking about 7-minute abs and he needed, he was going to come out with a company 6-minute abs. So there's a few studies out there. So we've got patellofemoral osteoarthritis 15 years after anterior cruciate ligament injury. The prevalence of patellofemoral osteoarthritis 12 years after anterior cruciate ligament injury. And then one of our colleagues up at La Trobe, Adam Colviner, released this one. Early patellofemoral osteoarthritis 1 year after anterior cruciate ligament reconstruction. So I think he's just got in there and I don't think anyone's going to beat him anymore. So good on you, Adam. But yeah, so we can definitely see that there's obviously a bit of a link there with ACL injury and patellofemoral osteoarthritis. We spoke briefly about the continuum with patellofemoral pain. So these people, again, perhaps having pain maybe developing when they're in their adolescence. So there's a long time to have anterior knee pain. But they're going through, they may actually end up with patellofemoral osteoarthritis, which, as we said, adds that layer of complexity to their presentation. This has been touched on a few times tonight. So anatomy, trochlear dysplasia, and patella alta, these have been recognised risk factors for osteoarthritis or patellofemoral osteoarthritis as well. We'll go through those again. So the management of knee osteoarthritis. Hands up who's GLAD trained here. Only a couple, thought there might be a few more. So you guys would have seen this, infographic. So this is really all of the treatment options available to people with osteoarthritis, but also how you should access them as well. So obviously everyone should be offered this first line. The second line treatments, what we're talking about there is this shouldn't be really offered to people unless they've got good access to that first line. And then surgical options really only for people who have exhausted all of these options prior. So, and they've got poor quality of life and probably end-stage disease. So these are what we sort of understand. These are actually really well documented, good quality guidelines that we have for knee osteoarthritis. Management of PFOA. So, can we extrapolate these guidelines from an EOA population? The answer is probably an emphatic maybe. So there's, there's probably a few problems with some of this. So we understand, as we said before, people with patellofemoral osteoarthritis potentially having higher pain levels. So do we understand that, let's say these people with patellofemoral osteoarthritis may do worse from guideline-based treatment? Again, we don't know. The answers to these questions haven't actually sort of been performed in research yet. So what do we know about patellofemoral osteoarthritis and management specifically? So we do have some studies, and and again, this was sort of one of the roles of my postgraduate degree, was to try and compile some of this information. So we do have a little bit, which I'll hopefully share with you now. So this is one of the studies that I put together for my thesis, which is due to be published hopefully soon. But physical therapies for patellofemoral osteoarthritis, a systematic review. So this is looking at sort of physical treatments, so not sort of medical in terms of, let's say, medications and injections and surgeries, but we'll talk about that as a secondary. So just as we're going through this as well, so we talk about a few time points. So immediate term is just literally immediate, sort of straight after treatments. When we're talking about medium term, that's up to 6 months, and then long term, we're talking about beyond 6 months. So that'll be relevant just to some of these different items as we go through. So bracing. We do actually have some evidence for bracing with patellofemoral osteoarthritis. Now, we've got 3 studies that tell us that bracing can potentially improve people's pain, but also function in the medium term. The initial study, so David Hunter's study in 2011, so they did a little interesting study looking at, this is the brace they used here, but they actually compared people with the patella realigning strap to a brace without the strap. And what they found was that both groups improved, but there was no significant difference between them. So bracing actually helps, but the patella strap isn't actually significant necessarily in these particular populations. So the next study, so Michael Callahan's study in 2015, so they actually took that information and turned it into a separate study. So they actually looked at bracing and they actually made, I suppose, the patella strap optional in these people. So they did find that this was effective. So, so interesting information that obviously bracing helps, but the patella strap doesn't make a whole lot of difference. Taping. So Christian's talked a little bit about taping this evening from an instability perspective. So unfortunately here we have really poor quality evidence. So we have a few studies, some of them looking at, as we can see, tailored taping. There's one here looking at McConnell taping, which is just purely more of a medial glide. And we have some evidence to suggest that, well, these studies suggest they're, as I said, very poor quality, but the medial glide taping may offer some immediate pain improvements. And this second one, which we'll talk about in a moment as well, actually wasn't included in the study, but it does suggest that the taping may actually add something to exercise as well. So this particular study had a group that went through an exercise intervention, the other group that also went through the exercise intervention, but they added obviously the variable of tape, and there was a documented difference. K-taping, I think K-tape find it very hard to even sort of make it work in their own studies. So unfortunately, again, very poor. So one high risk of bias study. And yeah, really what they're doing here is comparing one intervention to an intervention that doesn't actually have proven efficacy itself anyway. So very hard to sort of read anything into that particular intervention. So foot orthoses. So we've got, again, 3 small studies here. So these particular studies have all very mixed results. So these are all pilot-based studies as well, so with the hope of obviously jumping into something a bit larger down the track. But we have, so prefabricated orthotics may improve pain and function. One study says that they may, another study says that they may not. And then we also have another study done by Narelle Window, which actually suggests that custom orthotics also may not help people with patellofemoral osteoarthritis as well. So we're not winning on too many fronts here, are we?
Could that be because the customised ones are more rigid?
It's a great question, and we're hanging out for more information and evidence here. And there is actually a big study that has been performed at La Trobe. We're just waiting on, I suppose the data actually don't have any of that information. I asked Christian for it the other day and he didn't know either. But we're waiting for that to be published. But I don't think they were looking at customs. I think they were more the prefabricateds. Yeah, so they're looking at that there. But yeah, as far as why, that's a good question. So what about exercise? We haven't talked a lot about exercise at all here. So we know exercise is obviously, that foundation, that first line treatment. So what about exercise for patellofemoral osteoarthritis? So we do actually have a few, and this, as part of the systematic review that I put together, this was actually the only treatment modality that we could actually pull a couple of different studies. But what we have here is actually sort of a group of multimodal studies. So these are not exercise by themselves. So this is what we'd sort of term multimodal physiotherapy. So what they've included in most of these studies is several interventions. So the Crossley study, for example, they did exercise, they did education, they did taping, and some manual therapy as well. So it's a combination. But exercise is obviously one of the big parts there. And we do actually have a bit of evidence. So we can see those of you that are familiar with forest plots here. So we can see that the whiskers here are not touching our line there. So that sort of indicates a significant result, and then obviously the pooled result down here. So we can actually see that there is a bit of an effect there. So this is pain in the immediate term, and then also function in the immediate term. So we do actually have some evidence there for this multimodal approach. And then in the medium term, we can start to see things wash out a little bit, but we do actually have, as we can see here, the 2 pooled results actually sort of do create something that's significant there for pain in the medium term. But then as we get down to function, as we can see, it starts to wash out. So this is probably some of the challenges with these sorts of studies is people obviously drop off. They don't continue to do these interventions after the study ends. So they, when they do these sort of longer term follow-ups, we find that sometimes the results start to slip. So it's important that we probably understand what exercises were done in these trials so we can sort of make a few judgments about what might be appropriate. So in the Crossley study, so again, you can sort of save judgment maybe until the end for some of these interventions, but functional, so they broke it into functional and then there was some strengthening exercises. So we can see there was either a sitting VMO exercise a sit to stand, and then a step up or a single leg squat. And then we had some quad strengthening, which was open chain, inner range or mid range, and then a wall sit. And then hip strengthening, they did some side lying exercises. So the information that we had about the dosage there was 3 to 4 sets of 10 to 15, and the physio really guided the progression. So we don't have a huge amount of information about intensity, so that's sort of not really giving us a lot of information there. So it makes it a bit hard for us to perhaps reapply some of this stuff in the clinic. We get even less information when we come to the sit study, so active non-load VMO exercises, so in terms of how long they were held for, the intensity that people were sort of experiencing during this is not a lot of information. And then with the quilty study, this one actually wasn't pooled, but VMO exercises in sitting, gluteal muscle contractions, controlled sit to stand, so 10 maximal isometric quad contractions and single leg balance. So again, so you wouldn't necessarily call these exercises heavy strength training, so we'd probably throw them into that perhaps neuromuscular type category. So that's sort of the evidence we have there for patellofemoral osteoarthritis. So what about medical interventions? So we did actually perform a study that actually looked at this as well. That was I was able to include as part of my thesis. So we looked at actually this was combined with a group from the Netherlands. So they were looking at doing a study particularly on patellofemoral pain, and I was looking at patellofemoral osteoarthritis, and we combined the two studies. So which I think helps strengthen probably some of the arguments. There was very little studies to do with patellofemoral osteoarthritis. So actually most of the studies that are included are actually more to do with patellofemoral pain. But just an overarching conclusion here, so very limited to limited evidence for all interventions, often compared to other interventions that don't really have established efficacy, which we spoke about before with the taping. So we're really unable to make confident recommendations as to which of these interventions are going to be effective. But we'll delve into some of these a little bit more specifically again. So medications are injections. So what we're looking at here, there's actually only one study that included people with patellofemoral osteoarthritis. And this suggested that glucosamine did actually have a bit of an effect, but we can see that it's very low certainty. So this is very poor quality research. So we can't sort of make a lot of conclusions here. And as I said, the rest of the studies there were patellofemoral pain related. When it comes to surgery, so this is where we do have maybe a little bit more evidence. So there was 2 studies included within the systematic review that included people with patellofemoral osteoarthritis, and both of these were studies looking at patellofemoral arthroplasty, and this was compared to total knee arthroplasty. So what they actually found was that there was some improvements in the immediate and also medium term compared to total knee arthroplasty in people with really isolated disease. So this is something that we'll just touch on in a moment, and we'll probably get Julia's thoughts on this later maybe. I suppose the inclusion criteria for these particular surgeries are pretty narrow. So interesting to hear what sort of Julia's thoughts are on that. So as we said, so we had immediate and medium term that was included probably within the systematic review, but there has actually been an update. So the ODGARD study actually did do a longer term follow-up. So 6 years, so they did a 6-year follow-up of their cohort, and they still found that actually there was an improvement in the patellofemoral arthroplasty group. So this could potentially be a good option. Obviously, I think sort of further replication is probably needed here, but it does seem to have some of those longer term improvements and longer term over a arthroplasty in people with isolated problems. So the authors did forecast here, however, that they believe that it'll probably wash out after 6 years. But we're actually saying that in our systematic review for the medium-term results as well. We thought it was going to wash out after that, but clearly it did last a little bit longer. So what does it all mean? So just trying to sort of give a bit of an overarching summary of some of the data we've just presented there, because there's a lot, or not a lot that necessarily is particularly positive. But exercise or multimodal physio can have a positive short-term effect. But we're putting our clinical hats on here as well. How might we be able to maintain this in the longer term? We may need to sort of supervise these people for longer periods of time. So that's probably one thing that we can perhaps do in the clinic to get some longer-term benefits. So there may need to be some ways, as we said before, people with patellofemoral osteoarthritis do have potentially high pain levels. So we might need to find ways to actually reduce pain with exercise for them to have the same benefits as their knee OA compatriots. So this is things like taping. So the SHAR paper there, I think more replication is probably needed for these sorts of things to actually see, can we add things to exercise to make that more effective for this particular cohort? So anecdotally, and I've actually, since looking at a lot of these studies, I've actually given or recommended a few of the braces to some of my patients. And anecdotally, they do find it very bulky. As you can see in that picture earlier, they're quite large, even with or without the patella strap. They find it very hard to exercise in particularly as well. So that is something to think about. Although we have a little bit of evidence there to suggest that they may be beneficial, we've got to think about the practicalities of it. We don't have a lot of info about injectables or other medications for patellofemoral osteoarthritis, but obviously there is a bit of information there for people with knee OA more generally, so we can potentially borrow some of that information for our PFOA cohort as well. Isolated patellofemoral replacement may be more effective in the short and medium term, but maybe the longer term as well, as we said, so with that more recent uptake. But finding that unicorn that will benefit, so with that really isolated disease, is pretty difficult. Yeah, so there's not going to be too many people out there that are really probably going to benefit from that surgery anyway. But as I said, I'm interested to hear what Julia's thoughts on that are. So we've got a little bit of evidence there. As I said, we're not sort of super specific when it comes to patellofemoral osteoarthritis, but we do have some really good guidelines when it comes to NEOA more generally. But what is actually offered to people with patellofemoral osteoarthritis or NEOA more generally as well? So with physios, so this is actually a few studies that Christian led looking at, I suppose, people's beliefs or physios' beliefs, so around treatment for knee osteoarthritis. So one group was actually sort of pre-GLAD course, I believe. So these are all people that were obviously interested in learning more about knee osteoarthritis. And I think another group was actually recruited from social media, but 38% were aware of clinical practice guidelines, so it's significantly less than half. 26% believe that imaging is required for a diagnosis. 43% believe that evidence supports stretching for knee osteoarthritis. And 24% not aware that arthroscopy is not supported for knee OA, and 52% believe that evidence supports arthroscopy and exercise for early OA. So again, some beliefs there that we understand obviously to be not true. GPs, now this is an interesting one because again, the vast majority of people with patellofemoral, but also just knee OA more generally, are going to be going through their GP. So there's two studies here that were, again, replicated about 7 years apart. So the Brand study, so I've got the stats there, which is the first number, and then the Benell study, which was the second number there. So these are a proportion of people with knee osteoarthritis receiving these treatments from their GP. So anti-inflammatories, 28 to 21, paracetamol, 22 to 26. Opiates actually went up, which was amazing. So we have very strong evidence to suggest that they shouldn't be offered to people with osteoarthritis, but they're providing more of those these days than they used to. Non-pharmacological, so this is obviously where some of the evidence sits, is where the guidelines sit. So imaging's gone up, as we can see, and we'll talk about that in the next slide as well. Orthopedic referral also gone up. Physio, we've got a little bit, so we've just snuck in there. Good, it's heading in the right direction, but it's very, very low in comparison to a lot of the other treatments that are offered by a GP. So this study was released in 2020. And this is looking at, I suppose, surgical trends over time, in particular with arthroscopy, which is the blue line in both of those graphs. Knee replacement, which is the yellow line, and then medical imaging or MRI referral in green. So who can tell me what they think happened in 2013? Medicare changed the billing codes, and GPs are all of a sudden able to refer for MRI for knee osteoarthritis. So we see a massive jump in the amount of MRIs that have been referred for. But I'm going to tip my cap to Julia's mob. We don't see massive increases in arthroscopy or knee replacement, which is fantastic. No, yeah, correct. But interestingly, we do. Like there was a study actually done in the UK. They looked at sort of important findings from MRIs. I think it was about 8% of MRIs referred from a GP actually found an important finding that might have actually been relevant to their situation or their pain, at least. But 67% of those people were referred to a surgeon to correct the findings that they found on the MRI. Yeah, so this is, I suppose, the risk that we're looking at with sort of these increasing MRI referrals. But yeah, as I said, we do see obviously an increasing amount of total joint replacements, but as we were talking about before, this is probably due to ageing population. We saw that 126% increase in knee osteoarthritis since 1990. So these stats would suggest there's just more people out there with obviously knee osteoarthritis. We can see arthroscopy diminishing. We know that there's some pretty strong evidence now to suggest that this isn't particularly helpful for people with knee osteoarthritis. But that first study, that first randomised control trial that said that was back in 2002. 2009 was when it was all compiled into a systematic review, and we probably don't see the numbers start to drop until about 2013, 14. So this is just, I suppose, the delay that we see in research translation, which is very slow. It's a very slow moving train, unfortunately. What influences people's decisions about PFOA treatment? So this is my one of my key studies with my postgraduate thesis. So we actually did a qualitative study. We were looking at people with patellofemoral osteoarthritis, and we were interested in how they made decisions about their care. So what options did they choose and why? So we were able to sort of distill down and to some key themes, and we were able to sort of grade them into what we thought was like a participatory influence, so various themes that might have actually influenced their treatment choices in a positive way, so things that might have been about participation and those sorts of things. An impairment influence, which is things about that are really focused on that pathoanatomical changes and those sorts of things, which they might choose really sort of biomechanical treatments as a result, and obviously things that might sort of go either way. So we had some intrapersonal factors, so some things that were a bit more about the person, so their preferences, levels of pain, the way that they spoke about knee osteoarthritis as well, so their discourse. So we had people that spoke about it in both ways, so impairment and also participatory discourse. And sometimes some people did have preferences for exercise as well. There was obviously a fair few barriers, so lack of results maybe previously, lifestyle and time, maybe pain was another big factor as well. The next layer there we have is sort of more this interpersonal layer. So this is the clinical encounter. This is the appointment with you guys. And this was probably a really big one and probably some of the real key themes. So we spoke about, and Christian was talking a lot about language and sort of how we communicate about osteoarthritis with these people and how much of an impact that can have. So we see here impairment discourse used by clinicians, but also participatory. So there were obviously some good, good messages that were communicated out there. Therapeutic alliance, and this actually came through as a really strong theme as well. So therapeutic alliance is that relationship that you can develop with your participants or with your patients. So this obviously could have an influence either way. So if you had a really good relationship, but you're telling them they've got all this stuff going on in their knee that's going to fall apart, that's going to have a bit of an impairment influence. But yeah, that is a really, really strong theme that came through. Medical imaging, which was another big one, so we spoke about that before and I suppose the impacts it can have. And social networks, so these people actually did speak a lot about their problems to their colleagues and their peers. So this was something that was actually sort of quite a strong theme that came through. And the very last one there, so we did the majority of this study actually just around COVID time. So barriers to exercise, people actually found that obviously due to lockdowns, things like that, they couldn't go and participate in their exercise classes or potentially even catch up with their physio. So that was a bit of a problem there as well. So just in conclusion, some of the sort of more powerful and stronger themes that sort of came out in that research was, clinicians really do play a central role in treatment decision making. So this is really through how we communicate, how we speak to them, so the language that we use, the recommendations we make, and also things like medical imaging. Do we refer, or if we do refer, do we explain those results in context? So those sorts of things are really, really important. That therapeutic alliance also really, really important, and this can really improve people's confidence in their decision making. But it can be for the better or the worse. It really depends on the above things as well, your recommendations and how you're potentially talking about the conditions as well. So that is it. Thank you very much for your patience and your attention. We might get into the last little section here. So I might actually ask the presenters and also Reese to come up the front, please, and we'll just run a little Q&A. Thank you. Okay, yeah, all right. Does anyone have any specific questions in relation to one of my favourite topics? Yeah.
Do you think that the term about the second slide was where the PFOA is linked to PFOA? Do you think that's due to changing the mechanics when they have the PFOA, pain and stuff like that, releasing PFOA?
This is my sort of gut feel, and I think Christian can probably back this up a little bit, but I think it's potentially more due to things like inflammatory change and things like that. They probably have a lot of the risk factors to develop PFOA in the first place, and those sorts of things obviously cascade over time, so they can actually start.
So I'm going to talk this evening about managing patellofemoral joint instability. This is a big passion of mine. I wish I saw more of them, not because I wish more people got injured with a patellar dislocation, but a lot of them are really mismanaged in the early stages. Who works in ED here? Anyone? Any emergency department physios or consultants? No? No one. They're the ones that typically see them. Then they often go off into the community and they might present to me 6 months down the track, 12 months down the track, sometimes had surgery, haven't had surgery, but often it's the first 4 to 8 to 12 weeks it's really mismanaged. So a couple of disclosures from my stuff here before I start. I teach courses related to running a knee injury. I have some not-for-profit initiatives which I'll flag. Some of you will be familiar with GLAD. The other one is TREC, which is a research translation initiative I set up a number of years ago, and I'd encourage you guys to look at that. I've got some resources that will hopefully build on what we present tonight related to kneecap-related pain. So there's clinician-facing resources and patient-facing resources. So we jump into patellar instability. So what are some of our considerations? I guess we have anatomical considerations, and I'm sure Julia will talk to you about some of these and some of the surgical considerations around that. And in particular, things like trochlear dysplasia. So how deep is our trochlear? Sometimes you see people that have just a completely flat trochlear. I don't know if you've got any experience of seeing a bump trochlear. There's actually the opposite. So some of these things are, as a physio, I look at it and go, well, there's nothing that I can do here. A lot of dislocations though, There might be a little bit of trochlear dysplasia at play, but it's not usually a huge factor. Patella alta. So patella alta is a common thing I find patients fixate on. They say, I've been told I've got patella alta, and sometimes it's really mild, so the patella just sits slightly superior to what would be ideal. The higher your patella sits, the less congruent it is with the femur, so it's going to be more likely to be painful, unstable, possibly dislocate. But it's not the be-all and end-all. And then increased Q angle, and everyone really focuses on this, and sometimes looking at it statically and dynamically. So thinking from a dynamic sense, what is our actual valgus angle happening here? And again, a lot of people will focus on that. Ligamentous laxity and impairment, I think, and I'm sure Julie will talk about this later, this is something, if it becomes a long-term problem, multiple dislocations, this is where surgery can be really valuable, thinking about medial patellofemoral ligament and stability there. But hopefully if we manage an acute injury really well, we can actually help that to heal and heal with some decent stability. And then general hypermobility. This is my wheelhouse as a physio that I love to work on, and that is muscle imbalances. So thinking about medial weakness of locally, so thinking about your quadriceps muscles, that's going to be really important for patella stability. Thinking about potential tight and tonicity, so thinking about lateral quads, lateral hamstrings. Sometimes soft tissue work, hands-on things can help those with patellofemoral pain or patellofemoral instability, but often it's driven by the fact that maybe the medial muscles are weaker. So we've got to try and think about addressing that. Hip weakness I'm going to talk about more later, so thinking about gluteals in particular and why they're important. And then also kinetic chain movement patterns. So most dislocations will happen in a closed chain position, and that closed chain position will often be some sort of valgus force as part of it. And that may be driven by the hip, but it may also be driven by what's going on distally as well. So we need to think about the whole kinetic chain when we're rehabbing people. I'm going to introduce you to a patient, and I'd say a really good friend of the clinic these days, who actually helped us build some of this place. You can ask him about that later as well. It's a wonderful clinic setup named Reese. And I met Reese probably nearly 10 years ago, or about, might have even been more than 10 years ago. And it was quite a confronting consultation, and his journey of persistent anterior knee pain started with a dislocation and ended from a surgical perspective with a patella replacement at the age of 30. So I'm going to introduce and let Reese tell his story, and it's going to be wonderful chatting to him later.
Before his first surgery at 18, Reese tried Physio to treat his constantly dislocated kneecap and the osteoarthritis that led to, but they couldn't help him.
My first surgery had a massive impact on me and everything I did at the time. I lost 15 kilos in about 4 weeks. I had to quit my job, I quit sport, everything that I've done on a day-to-day prior to surgery, I could no longer do anymore.
But that was just the beginning of a long ordeal. 13 years on and another 10 surgeries later, his quality of life had deteriorated.
The pain I was in was unbearable. Not being able to sit in a comfortable position, not being able to sleep in a comfortable position, being in that pain just incredibly pain. The constant haze of pain on pain relief just sucked the life out of me.
At 31, unable to even make it to work without excruciating pain, Reese was ready to give up.
I was very heavily depressed at the time. I was suicidal. I felt like nothing left in my life left. It came to because everything I enjoyed, everything that I loved to do was taken away from me.
So I saw Reese more than 10 years down the line from his original injury. We can ask Reese some questions about what he did, if he can remember when he was a kid, when he first had that dislocation. But he had a lot of passive care, a lot of focus on pathanatomical problems. You go from GP to surgeon, maybe not operate, maybe operate, to physio, lots of passive care that's low value, dry needling, ultrasound, a whole range of things. Told, yeah, your knee's pretty bad, you're in trouble, let's see what we can do. Not going well, back to surgeon, another option, working through that process. Ended up with a patella replacement. We'll come back to his case because it's quite phenomenal what Reese can now do these days, despite everything that he's been through. And I get a sense if we had given him some better education and better guidance of exercise, even after maybe the early dislocation was mismanaged, he would have done well. Had we have managed him really well at the beginning, he might have done very, very well. So, but unfortunately, we can't turn back time. So there's not a lot of research to guide non-surgical care for a patellar dislocation. There's not many great trials of protocols. So when I think about these, I like to think about some of the principles, and I do this for a lot of conditions and a lot of treatments that we provide. So acute dislocation management, we have an inflammatory period, 0 to 72 hours. This is no different to spraining an ankle. So if we sprain an ankle, we're going to try and play football or netball 2 days later. It's probably not a good option to do. We want to try and manage it well. So we have vascular response, we have bleeding, we have hematoma formation, and this is all really important for healing. We actually want this to occur. We shouldn't take anti-inflammatories to stop it. Well, that's a whole other topic. We actually want this to occur. This is a normal healing process to go through. What we need to do is to protect it. So in the case of patellar dislocation, probably a Zimmer splint actually maybe makes some sense, especially if you've got someone who's not going to non-weight bear and stay off it. So keep their knee straight so there's no stress through it. If not, keep it as close to 0 degrees as possible and get the crutches, non-weight bearing. Try and protect it. That first 72 hours is really important, just like an ankle injury. If you want to manage an ankle injury really well, first 72 hours, stay off it or put it in a moon boot. And then you start to mobilise and get moving. So this is no different. Then we move to the subacute phase, so moving past that 3 days. With any injury, what we can do as exercise professionals is try and promote and optimise healing and also prevent iatrogenic effects of immobilisation. So whenever you've got an injury, whether that's a fracture, a dislocated patella, a sprained ankle, there's a balance between protecting and allowing the injury to heal and preventing iatrogenic effects. So it's a balancing act. So we want to minimise joint stiffness, we want to minimise muscle atrophy, and we want to set someone up for a really good long-term outcome. So if we splinted someone in a Zimmer splint for 4 weeks, that's not going to lead to a good outcome because there are going to be so many iatrogenic effects. So that's a really important thing for us to consider. So in terms of the repair phase and thinking about that first 2 weeks, there's a lot of stuff going on. We want to promote early collagen organisation. So there is a laydown of collagen and tissue healing, and we want to optimise that new tissue. So no load on a tissue is not good for it. I'll tell you a really interesting side fact that I learnt. See my fracture here? Fractured arm. Yeah, everyone can see the nice scar. If you look at the RCT evidence for casting a fracture that is stable of an ulna or a radius, so not joint related but stable mid-shaft, casting it for 4 to 6 weeks versus not casting it and doing a few things with it but being really careful, which option do you think heals better? Backslab or not casting it. The problem is if you don't cast it, what do people do? Stupid things, and they refracture it. So it's a balancing act, and the reason that it heals better when you don't cast it and you actually allow some load is it's putting load through the tissue to help it to heal. You just need to make sure you don't put too much load. And it's the same for this sort of stuff. I read a lot about upper limb fractures despite being a lower limb specialist physio. So we want to optimise and we want to try and help formation of new tissue for ligament. Now I asked ChatGPT to make me this graph. It's kind of cool. What I asked ChatGPT to do is there's lots of research around looking at patellofemoral joint stresses through different knee angles, and I particularly wanted to pull together the medial patellofemoral ligament joint stress, like what actually happens with this. So as you go through knee flexion angle from 0 through to 120, you can see the amount of stress through the patellofemoral joint and the medial patellofemoral ligament increases. If you look at the first dot on the graph, so we're looking at about 30 degrees, there's not a whole lot of stress going through that ligament yet, but a little bit. As you go towards 60, 90, it actually increases quite a lot. So when I think about how would the best way to manage this, and I don't have an RCT comparing limiting range to 30 versus limiting range to 90 in these first few weeks, but logically to me, we want to allow some movement, some load, but I tend to try and keep people to 30 degrees. Not much more than that in those first couple of weeks. Now you could argue you shouldn't allow any. You could also argue you could allow more. So I feel like that 30 degrees is a nice happy medium. As I said, I don't have an RCT to compare it. This is my clinical approach, thinking about what science we do have, even augmented by ChatGPT these days. So when I think about trying to optimise those first 2 weeks, allowing, say, 0 to 30 degrees range of motion, weight bearing in terms of status, non-weight bearing initially, but from about 7 to 10 days when that really acute inflammatory and early remodeling phase is happening, start to take some partial weight bearing through it. Strength, you can start isometric quads at 30 degrees of knee flexion. I'll talk more about that in a minute in terms of load through the patellofemoral joint, but there's not a lot of load through the patellofemoral joint at 30 degrees when you do open chain of quadriceps. If you go deeper, there's more load. If you go into terminal extension, that can cause other problems with fat pad and other things. So usually around about 30 degrees. The other thing, if I'm managing someone with either acute dislocation and instability or chronic, that I think is often underused is taping. So patella taping is hugely valuable. So if you look at the research evidence around tailored patella taping, so this is thinking about looking at a medial glide, maybe considering rotation, tilt, I won't go into all those details now, versus maybe just a medially directed tape, the more support you give it, the better the outcomes are going to be in terms of pain during different activities. So this is not dislocation, this is looking at pain during things like stair stepping, during squatting, a whole range of different activities, and it's really effective in the short term, so in the short immediate term. The other thing that's really helpful for us to consider is how else can we optimise stability of the patella. So one of the things that I'll typically do is try and shift the patella distally. I find this incredibly effective for patellofemoral pain and incredibly effective for patellar instability. What did we say one of the risks for instability was patella alta. So if we can try and pull the patella distally, it can help with stability. So using a wide V, pulling up from here, pulling up onto the inside, pulling up onto the outside, can actually help to pull it down. So what I thought I might do is I've got a video about how to do this taping online. I'm not going to go through the whole video, but I'm going to take you through an abridged version of it and talk you so you can sort of see how to do it. Now the thing you'll notice on the video is there's a towel under my knee as I tape it. Don't tape a patella in terminal extension, 0 degrees, because as soon as you bend the knee, it compresses the patella, it's really uncomfortable, and the tape just comes off. If you tape it in about 30 degrees, you can get a really good hold on the patella and give it good support, and the tape's comfortable and doesn't tend to come off. So try and get that 20 or 30 degree angle. So I'll skip through the first part of the video, which is quite boring, me just laying down some Fixamol. And the reason we put Fixamol is so you don't get skin irritations. I'm going to show you guys this later. But what I will do is just talk through the images a bit better. So, medial taping, what are we trying to do? We're trying to pull the patella, which side am I on? Yes, trying to pull the patella medially. So what we're doing is looking for some small skin puckering here. In terms of lining up the tape, we don't want to sit too high on the patella and tilt it upwards. We don't want to sit too low and tilt it downwards because they'll become uncomfortable. So we want to go over central over the patella. These tapes here, what we're doing is we're actually starting here. We're using the tape, we're pulling the patella down and we're joining the tape here, pulling the patella down and we're joining the tape here. So pulling it inferiorly. So really simple. You can watch the video later, which will be helpful. So this is really helpful for creating confidence and stability in the early stages. So think about that acute dislocation, they're starting to partial weight bear and then get towards full weight bear over those first few weeks. Pop some tape on like this, they're going to feel much more confident. But then think about the kid you've got who's 12 or 16 weeks down the track who's thinking about playing soccer again for the first time. And their parents who are also worried about them. Put some tape on like this, it's a bit of a safety net for them to try and get back and play. It works a lot better than any of the braces out there. Yes, they're braces and you can try and use braces, and if you get sick of putting tape on, that's a great option, but if you practice the taping, it's the best way to get it and get control. So I'd encourage you to hone your skills on it. So some research. Thought I might talk to you about a couple of things which I found interesting. There's a really high redislocation rate whether you do surgery or don't do surgery. Surgery overall probably reduces your redislocation rate slightly if you do it in the early stages. I would argue that if we do a proper rehab program, you can probably also reduce your rates to a similar level. I found this study really interesting. So this was a 4-week restricted range of motion for 30 degrees. So fitting with my kind of clinical reasoning, but for 4 weeks, not for 2 weeks. So a longer period versus just a neoprene support, thinking about patella support, which will probably limit your range a little bit, but not a lot. Now, in terms of their study, comparing the brace to the neoprene sleeve, 34 versus 38% redislocation rate over 3 years. I don't know what your stats you've seen in this field, Julia, but that's pretty consistent with published literature. It's pretty high. About 1 in 3 will redislocate. So it's quite high. So the bracing, quite rigorous bracing, didn't seem to make a big difference compared to neoprene sleeve. This is where it gets really interesting, going back to managing iatrogenic effects. the neoprene sleeve was associated with better range of motion and less quad atrophy at 1 and 3 months. So they're doing more. The neoprene was associated with better functional outcomes, so subjective functional outcomes at 6 months. If you go to 3 years, there's no real difference. One of the challenges with the 3-year outcomes, only 64 out of 101 completed the trial. So there's a huge dropout rate. So we can't quite trust the stats on it. But long story short, if you limit the range of motion for too long, and too long might even be a month, you're going to lead to less or impaired outcomes compared to if you let them move and do some more. So that to me is a really important thing. So I go back to those principles. That first 2 weeks I think is really, really important. But after that, I think we want to try and start to load them up. So again, my unevidence-based but evidence-informed, if we call it that, way that I would approach this is by the end of week 4, I'd try and get them to about 90 degrees range of motion. So they should be able to get, and probably full range of motion by about 6 weeks. Weight bearing is tolerated, and full weight bearing, so from that 2-week stage, and then full weight bearing by about end of week 4, so in that first 4 weeks. Strength, I'd be doing a lot of isotonic, quads and hamstring with lots of medial focus. So how do you do that? So if you're doing a leg extension machine, so you're doing this, instead of just doing it straight, roll your knee out and do it this way. If you're doing a leg curl, you can do some rotation similarly. So instead of just doing a normal leg curl, you can roll your leg out and do the same thing so you get it medial. So you can do some really targeted medial strength work. Introducing closed kinetic chain, so more weight bearing quad stuff from about week 5, and then eventually getting back to plyometrics. So we've got these kids, right, who are 12, 13, 14, 15, 16, etc. They want to play soccer again, they want to play netball again. We actually have to teach them how to move again, how to rehab and how to get back to those activities. So introducing plyometrics is going to be really important. In most cases, I would usually find from about week 7, they're able to do that. And thinking about tissue healing time, 6 weeks, in theory, a ligament that's external to the joint should be pretty well healed. How long do we think an ATFL is going to take to heal? 6 weeks, everyone's pretty comfortable with that? Yeah. MCL, similar? Yeah. You're not going to push it too hard, but you're going to have some good healing by then. So then we work towards a return to sport, not before probably 12 weeks. So we've got a 6-week window after that 6 weeks to get back into things. So we cautiously bring this in. Then, secondary to that, we then need to think about the people who mostly come to us, who are many months down the track and haven't necessarily been managed that well as we go along. So if I go back to Reese, lots of catastrophic things told to him along the journey. So this is a published study from the UK, and it's about people with patellofemoral pain, patellofemoral instability. Quotes like, my heels have maybe gone in, which has pulled the kneecap out of alignment. So instead of going smoothly over the joint where it's supposed to, that it's probably moving over the bone, and that's the sharp pain I'm feeling. Now you could sit there and you could argue that maybe this person did have some alta mechanics of their feet that was contributing to the mechanics of their knee and was contributing to their pain. I wouldn't argue against that. But that description, what's that going to make someone do around exercise? They're not going to want to do anything. They're just going to sit on the couch and do nothing. They're going to be really worried. I don't know if he, the doctor, was trying to scare me into doing some exercise or something, but basically said the only thing they could do is break both my thighs, twist them in a bit, and then heal them back together. That's the only option. That's it. So that's a femoral derotation surgery, which is a pretty significant surgery. Is sometimes a very helpful surgery for stability, but for stability, doesn't help with pain typically in terms of outcomes. So that's a big surgery. Is there anything else that could be done? In most cases, absolutely. And then this is an amazing yet terrifying quote. They're saying that I'm a grandma. They say, yeah, if you're a horse, I'd put you down. This is a young person with anterior knee pain. So these are the sorts of things that we hopefully don't say as health professionals, but other health professionals will use. And so why this matters is because it creates disability. So that's the really key part is, I think most people would be familiar with the term kinesiophobia or pain-related fear. Those not, we'll talk through it a little bit. This is a nice measure, Tampa scale of kinesiophobia. I like using these questions with patients sometimes. So I'm afraid that I might injure myself if I exercise. If I were to overcome it, my pain would increase if I was to try to. My body's telling me something's dangerously wrong. My accident has put my body at risk for the rest of my life. So that may be correct for someone who's had a dislocation because we know that increases their risk of redislocation. But if they're strongly agreeing with statements like that, they're really worried about it. Although my condition is painful, I would be better off if I were physically active. So there's some positive slants, and then people will typically go the other way. So when you answer these questions, you get a really good understanding about how fearful someone is of their knee condition and how it might affect their life. When this is elevated, which it is in people with anterior knee pain, it will differentiate between high and low disability groups. So when you've got a group of people with anterior knee pain, you've got a really disabled group and a group that's less disabled. This is a clear distinguishing feature. Not muscle strength, not the way they move, not their trochlear shape, but this. This is the key thing that differentiates the level of disability. Doesn't mean all those things don't matter, but this is the thing that probably matters most from a disability perspective. So it really helps explain that level. So structure matters, but I would argue focusing on it too much can be really counterproductive. So it needs to be put in the context. So if they've got a patella alta, or they've got a sulcus that is shallow, you don't ignore it. You need to talk about it. Say, yes, it makes you more susceptible to be unstable. It might set you up to be more likely to have pain, but there's also X, Y, Z, etc., that is changeable, that we can help with. And that might be slowly building back to activity. It might be medial quad strength, hip strength, changing the way you move, taping, a whole range of other things as well. So we need to make sure we focus on lots of things. So this is a low back pain originally from the early 2000s from Linton and Van Leyen. And they come up with this concept of, I guess, a vicious cycle of someone having a pain experience, having pain-related fear, then catastrophizing, looking at the images, reading the imaging reports which sound catastrophic, health professionals giving catastrophic interpretation of imaging. They avoid behaviours that are normally activity related, so they avoid physical activity. They protect the knee. They start walking with a stiff knee. They lose strength, they lose power, functional capacity. That impairs their joint-related quality of life. They don't trust their knee anymore. What's it going to do to patella stability? It's going to decrease it massively. And then their health-related quality of life increases. And then if you look at the stats, people with anterior knee pain, just like people with back pain, 6 times more likely to be depressed. Put all that into the picture, they're going to have more pain experiences. And it just goes around and around and around. So we need to be really targeted to educate people to reduce that pain-related fear. So when I've got Reese in front of me, Reese, it is okay for us to do a leg extension exercise with a TheraBand. You'll be all right. It's not going to destroy your knee. We can do a little bit. Reese, you can walk up the stairs. So Reese, when I started with him, we were doing a step like this big, teaching him to just load his knee and get used to doing it because he couldn't walk up the stairs. Dave can talk about Reese later, but I can't remember how much he was back squatting in the first 6 weeks, but close to 100 kgs, Dave? Yeah, close. Yeah. So it was just step by step by step, tackling that. And then we can target rehab from there, and that's really important. So the key, I guess, things to focus on, medial weakness we talked about, and hip weakness. They're going to be your key drivers of patella stability and patella mechanics, if we look at the physical side. The other thing you'll notice I've put here is not just strength, but muscle power. Yeah. Who can tell me the difference between strength and power? Speed, yeah. So strength, the ability to generate force. Power, the ability to generate it quickly with speed. Our adolescent kids who want to go back and play soccer, football, netball, etc. Do they need to be strong? Absolutely. Do they need to be powerful? Yes, even more important. And that's what they often lack when they go back to sport. They'll do rehab, common Physio 101 exercise, let's do some single leg squats, yeah? That won't hit the mark for them playing soccer, won't hit the mark for them playing netball, football, etc. So that's really important. So if we go to quads and we think about that, I want to talk to you about some principles. In people with anterior knee pain, so this is not necessarily instability, although arguably we'll talk through that a bit more in a second, they probably do have a mild instability. But if you look at people with patellofemoral pain and you think about tracking, so everyone focuses on tracking a lot. If we think about that, groups with patellofemoral pain when they do MRI studies, you'll notice that as we go towards terminal extension in an open chain setting, you get a bigger difference in movement between patellofemoral and controls as you go to terminal extension. As you go to deeper flexion, there's less. So why is that? It's because as you move into terminal extension, the patella sits higher and higher in the trochlear, so it becomes less and less stable. So if it's going to track laterally, it's going to happen more in terminal extension. So it's also going to tilt more in extension. So if you're going to get mechanical issues, instability or pain, it's typically going to happen in terminal extension when you're doing open chain exercise. So in most cases, if I'm doing open chain quads for that reason, I won't get them into terminal extension. Or if I do terminal extension strength, which you do sometimes need to do a bit of, the load can come right down. Doesn't need to be so high. The other thing that I've put up here on the graph that you'll notice, if you look over to the left, is this is a graph of different patellofemoral joint stresses during different activities. This is a leg press. These two are different types of leg extension. What you'll notice is the difference between leg press, so leg press here, leg extension. In terminal extension, patellofemoral joint stress is really high. In leg press, patellofemoral joint stress is really low. And the key reason is it's the open chain mechanical arm that's pulling down on the end of the tibia that's causing that stress. Whereas if you do a leg press, it's very similar to a squat. So in this position here, there's not much knee loading, which is why in the early stages post-patellofemoral dislocation, this activity is going to be okay. It's the rotational movement we don't want with it, or a high force movement. The other thing that's important, you'll notice this is with a variable resistance. So what's an example of variable resistance exercise for leg extension? Therabands, yeah, resistance bands. Or a leg extension where the weight is entirely on your shin. Consistent resistance, so this one here is a cable machine like what we have here. So having a cable with consistent resistance coming up, you'll see the loads are similar. As we go through, you start to get more consistent resistance through, so it's a little bit more load. So arguably, we actually want a bit more load as we go through that deeper flexion to actually load the joint. So in the early stages of doing any patellofemoral rehab, whether that's instability, not instability, again, stay away from that last 20, 30 degrees, because that's where you'll get the irritation. More likely to track laterally and high stresses through the patellofemoral joint. So you're just going to irritate them. And then there's a fat pad that sits there too, sits under the patella. That also gets compressed in the last 10 or 15 degrees. So leg extension, I've got an orthopedic surgeon here, is a great exercise for people with anterior knee pain. It's a great exercise. And Julie's going to shake her head. Just don't do it in terminal extension, because you... I know, but you'll flare them up. You will flare them up. So we just stay away from it. Or we keep bringing it in carefully, isometrically, working through much lighter loads, because what happens when we get there? There's a lot more stress. And going back, do we need super strong quads here? No, they don't do that much here. They do a lot here. So we need to be stronger, deeper, not so strong as we go to terminal extension. All right, I've gone really geeky into biomechanics here, haven't I? It's fun. All right, you can chase the papers up too once you read the slides. So, tips for quad starting. Start isometric, because the other way not to irritate a patellofemoral joint is to stop it moving so much. So if you start an exercise isometrically, it's far less likely to irritate it. It is really rare I see anyone with patellofemoral instability, patellofemoral pain, patellofemoral osteoarthritis for that matter, that can't start an isometric quads exercise, particularly at about that 30-degree range. 3 lots of 30 seconds kind of sounds made up, kind of is, but also relates to very similar to exercise science principles, usually aiming for sets around 8 to 12. If you're doing them slowly, it's about 30 seconds of time under tension when we're thinking about strength and hypertrophy. So I'd start there. So going back to those 2 to 4 week patients post-instability, that's a good starting point. You can start to do that. Hypertrophy, we can then work on that 3 by 8 to 12, so slow movements. In terms of range, 90, might push it up to 20 degrees, but I still wouldn't go to terminal extension. Wouldn't go higher. You can focus on rolling the knee out, which is helpful. How do you dose it? You can try and do percentage of 1 rep max and things like that, but probably using RPE, so 7 out of 10, or maybe reps in reserve 2 to 3. Nice and simple. Then we can work through to trying to think about more generating pure strength. So this is sort of getting down the line. We might be 6 or 8 weeks down the track. 3 sets of 6, so you might go slightly lower, and you've got less reps in reserve, only 1 to 2 reps in reserve as we go through. And then the final one, which freaks people out, don't freak out, Julia, because this will really freak you out. You sit on a leg extension machine, you're at 90 degrees and you kick up hard, but you don't kick all the way to the top, right? So you kick up hard, so you're actually teaching the muscle to generate power. Bring it in with great caution. So when you first start doing it, kick up a little bit harder or a little bit faster. Faster again, gradually build it up. If someone's in the acute phase of rehabbing after a patellar instability episode or a dislocation and they haven't got a long-standing history of pain, you'll be able to do this stuff at around about 10, 11 weeks and they'll be okay in a lot of cases. You've got someone with a long-standing history, someone like Reese, who we mentioned before, or many other patients that've got 12 months or plus of injury, might take you 9 months to get to this stage, maybe longer. Still worth working towards, but it might take you a lot longer to get there. Be guided by pain as you go along. All right. Questions on quads before I jump to the hip? You can ask questions at the end as well.
And this is focusing more medially?
Yeah, so if you want to focus more medially, the simple thing to do is just roll into external rotation. Yeah, and then you'll get more medial quads. So if someone's got instability or they've got long-standing patellofemoral pain, my bias usually is to do that. Whether it matters every time or not is a great question, but you definitely get a lot more medial quads. So some of the physios who are a bit older in the room would have gone through doing EMG biofeedback. And if you look at the research around that, it doesn't really help with outcomes long-term of anterior knee pain compared to a good rehab program. There's not a lot of research on different angles for rotation, but if you try it yourself, try it with your patients, if you go into more external rotation, your medial quad's in a more favourable position, and I find it a nice way to get better contraction, and it's often less painful for people too if it is painful, so it often helps. Yeah.
Sorry.
Yeah.
Why is it important to like medial hamstring bias as well?
Yeah, so one of the things, this is very anecdotal, very, very anecdotal. One of the things that you'll pick up in a lot of patellofemoral patients and instability patients will be they actually are really tight in their lateral hamstring. One of the ways to screen for it really simply is if you do a straight leg raise, but in a neutral position, turn into external rotation, do it there, and they'll be a lot tighter in external rotation. Do some palpation through their lateral hamstring, it'll be super tight, super tonic, and just thinking about the biomechanics of that, if this is tight laterally, via the ITB, it's actually going to cause some lateral translation of the patella, so it might actually irritate that joint a little bit. So anecdotally, 0 trials to support that I know of, unless anyone else knows, but I'll often find you've got a squatting activity or stairs or something like that. If you can do some soft tissue work through the lateral hamstrings, it'll typically have a really positive effect on their pain during those activities. So try it with a couple of patients and see how it goes. If it doesn't work for you, move on and say Christian's an idiot. Yeah. Yep.
Are you ever going into that less than 120 degrees?
Yeah, so I will. I usually work on it if people feel like they're unstable with their knee through that range. That'll be a really common reason to do it. So a lot of post-ACLs, I'll end up being like that. I find a lot of patellofemoral patients don't need to work on it too much, but if you go into it, I'll usually start isometrically. So I'd sit on the machine and just hold it there in pure extension and just hold. So not actually working through any range, so it's less likely to irritate. And then from there, if they've tolerated that well for a couple of weeks, then I'd drop into a bit of flexion and then back up again. And so I'd often do 2 types of quads exercise. I'd do say 90 to 30 or 90 to 20 heavier, and then much lighter terminal extension dropping into 20 or 30, but much lighter. So if they're doing 40 kilos in the heavier one, they might drop down to 20 kilos for the terminal extension. I think it can be valuable. Yeah.
And would you have the same recommendation for someone with patellofemoral OA?
Yes.
So if you're doing like extensions like in GLAD, you'd stop short of that 20 degrees?
Yeah, absolutely. Yeah. So I know in GLAD it's very simplistic the way it's taught, which is for a reason, but I play around with all these nuances and a lot of the patients you see doing GLAD, they'll have PFJ OA alongside their TFJ OA. So they've got PFJ OA, a lot of principles we've been talking about here, even if you're using therabands, going into more external rotation, limiting your range, starting isometrically, it's really helpful. Yeah, really helpful. All right. So I want to touch on the hip. So I just like showing this because it's my wife's cousin and she's got amazing biomechanics and some anterior knee pain. So I don't think doing quads exercises for this girl is going to do much for her mechanics. What do you reckon? So left side. You're not sure where to look, right? We're looking at the pelvis, we're looking at the foot, we're looking at the hip, the knee. There's all sorts going on. But a key thing for her is she's got a lot of femoral internal rotation. Structurally, she has femoral anteversion. So she's always going to run like that a little bit, no matter what we do. But there's a lot going on that we need to consider. So in terms of the hip, there's some interesting research out of the States in Chris Powers' group. This is Rich Souza, who was a postdoc working with him a number of years ago. He does some really cool weight-bearing MRI studies. So they actually look what happens to the femur and the patella through different ranges of motion. And so what you'll notice in a weight-bearing position, if we look at lateral patellar displacement and patella tilt, we can see that as we go through controls compared to those with pain, you can see that angle kind of changes. So we're basically getting a bigger difference, that lateral translation and tilt that we talked about before. So the question is it the hip that drives it, or is it the femur that drives it? Because if it's the femur, is it the hip that drives it, so up here, or is it the patella driving, so quads balance? So if you look at some of the studies that they've done, you can see some really cool information around how things move relative to space. So that lateral tracking that you're seeing is not because of the patella moving in space, it's because of the femur moving under the patella. Yeah. So the patella is moving laterally, but the patella is not actually moving laterally. It's kind of staying in the same spot as they squat. It's the femur that's moving inwardly in a weight-bearing position. In some other research that they've done in non-weight bearing, so leg extension, the femur stays still, so that makes sense, but then the patella moves. So that's where the medial biases may be important for your quads. But here, it's going to be hip muscles, gluteal muscles, so they're going to be really important to control that. So hip, just to highlight the importance of it, I used to love doing systematic reviews and had lots of students do them, so we did quite a few in this space. This was looking at hip rehab for patellofemoral pain, and then we also looked at prescription principles. In some of the trials we looked at, there was literally pogo stick rehab trials that people did. So jumping on a pogo stick, through to leg extensions, whole range of things. What we found is that hip and knee exercise helps people with anterior knee pain, but in the short term, if you target the hip, if someone's got an anterior knee pain condition, targeting the hip rather than the knee is going to be more beneficial in the short term. And if you think about it, it makes logical sense, because if you're giving someone knee exercises with an irritated knee, you're more likely to just contribute to that. So it doesn't mean you don't need to rehab the knee, because in the long term, rehabbing both is better than doing either alone. But in the short term, hip's going to be more valuable. So even in the really irritable PFJ patellar instability, a lot of the hip stuff I'm about to talk about now, you'll be able to bring that in. So even if you want to leave the quad stuff for a month or 6 weeks before you bring that in, you can usually start with the hip stuff without too many issues, and they're going to do well. So what are our prescription principles? Unfortunately, all the trials in this space, like any exercise study, they don't really describe things very well as to what they've done. And that's like most areas of research. So one of the things that you'll notice I'm passionate about is restoring muscle power. And so I wanted to test this a few years ago, and the simple principle being, how are we going to run? By just doing single leg squats. Like, we need to actually restore muscle power. So these are not instability patients, but I think they have really good, or this study has really good context for what we're talking about tonight. So we did a 12-week program, 3 times a week. I had 2 physios treating in the trial. They were only allowed to give a max of 3 exercises. I asked them to try and limit it to 3. Try and only give 3 exercises. That's tough for some people to do. They had 5 to 8 physio consults. Actually, the most consults that anyone had was 6 in the trial. And they're only allowed to give exercise. No education. You're just going to give hip exercises. And later down the track, you can bring in some quads and hamstring if you want to, but it was purely focused on the hip. So it was only a small study. We had 11. We had, out of those 11, 1 dropped out of the study. They became pregnant. So at about the 3 or 4 week stage, they had a lot of pregnancy-related sickness, couldn't continue, so they dropped out. We had 1 pain flare, and that was because the physio gave them some squatting activities to do and it flared them up, so then took it away and they continued on. We tried to get them to do strength, so that strength prescription we were talking about before, but this time for the hip, and then progress towards power. So they're doing power-based exercise by 4 to 8 weeks for the hip. So you can progress it pretty quick. We had really poor data. We tried to, does everyone use PhysiTrack? Yeah. So everyone used PhysiTrack in the first 3 or 4 weeks. It was wonderful. And then after that, they stopped using it, so we had no idea what they were doing anymore. So we should have just used a paper diary like we used to always do. But this was back in 2017, and we thought, this is amazing. We can get all this wonderful data, but patients didn't use the app properly. I'm sure you still get the same these days. What did we find? Well, in terms of hip abduction, which is typically about 20% down, we saw a 35% increase in hip abduction and extension strength. And the way we measured that is we did a side-by hip abduction exercise. So we measured that in terms of isometric strength, and we measured a 10 rep max using a cable machine very similar to what you can see behind you there. We also measured power. So this we thought were quite novel back then. We didn't have AXIT and we didn't have VALD and all these things. We just attached a device onto a cable so we could measure their hip muscle power. We found some big improvements in that. In terms of their pain outcomes, it was a massive improvement. So they went from an average of 5.7 down to 1. Remember, just hip targeted exercises. So I'm pretty confident if we added some knee and probably some education, they would have done better. One of the things you'll notice on this graph, remember, no education, nothing else. Kinesiophobia didn't really change. Their physical activity levels didn't really change. So they got stronger, their pain got better, but they were still worried about doing things. So I think we would have got some better outcomes with some other things. So this is the website that I talked about before. So mykneecap.trekeducation. There's a whole bunch of resources that will hopefully help you with education, providing information about imaging and other things about where it does and doesn't relate to pain. There's also a lot of exercise resources. So the exercise program, as an example in the study I just talked about, started off with side-lying hip abduction, work on neuromotor patterning, making sure gluteals were functioning well, but then progressed in towards standing related, and then progressed towards more gym related, and progressed towards more strength and power related stuff. So really simple stuff. And to be honest, the stuff we did here, very similar to what we did with Reese in the early stage in terms of exercise prescription. Really simple things. So I thought I'll just finish and I'll let Reese tell some of his story now. You can ask him a lot more questions later.
While going pain-free was almost a miracle for Reese, his proudest moment came 2 years later.
Just ask the surgeon, am I going to be better with the surgery compared to not having the surgery? It's a really simple question that nobody asks. What's the evidence that I would be better with surgery than if I didn't? My colleague Lucky completely different thought by 3 or 4 years ago. Thank you. I can do all the things that I used to sit back and watch my mates do. I don't have full functionality, but I have a lot. And it's great to be able to be included, be able to do all the things that was never able to do.
So I think when I talked to Reese, there's probably some surgeries in amongst that he probably ended up needing, probably because it was not managed well early stages, but there was probably a bunch of things that weren't needed. He had 10 surgeries, that's a lot. So that's a lot, one on his other knee. So to summarise, a few key take-homes. Patellar dislocations instability can have a marked detrimental impact on people's lives. So we all see these stories all the time. Early management is really key, and if we can manage things really well early, give the ligament the best chance of healing. Doesn't guarantee it, but it gives it a good chance of healing. Hopefully, if you can manage it well, that 1/3 that redislocate, we could probably bring down a little bit, I would have thought. When you are managing these people, protect, but don't be too protective. So it's a balancing act. And we don't know the exact process there. I'd love to see some more non-surgical protocols. There's lots of surgical comparisons, there's lots of surgical case series. There's very few good quality non-surgical case series or RCTs, etc. Be careful with what and the how of education. And that's from the early stages, even when they first dislocate. So you need to talk to them about the structural reasons that might have set them up to do it, but don't just focus on that. Let's focus on all the other things that they can manage. And some of them, they will need to go straight to surgery depending on the structure. So if you're unsure, I'd refer to a surgeon, get some opinion, and find some people you can work with closely. Address their functional stability. So be aware of the structure, but focus on function as much as you can. You've got to think about quads, hip, and the whole kinetic chain. Think about muscle strength and power. So I'll send these out to everyone, and then they're the 2 websites. So patellofemoral.trekeducation and mykneecap.trekeducation. But thanks for listening.